Hi everyone, welcome to this evening's webinar, Thyroid Nodules, Thyroid Cancer, and Primary Hyperparathyroidism, What GP Needs to Know. My name is Serena, your RCG representative for this evening. We are joined by our presenters, Dr. Douglas Shaw, Dr. Veronica Prida, and GP facilitator, Dr. Vani Andrumanamani. Before we get started, I would like to make an acknowledgement of country. We recognize the traditional custodian of the land and sea on which we live and work, and we pay our respects to elders, past, present, and emerging. I would also like to acknowledge any Aboriginal and Torres Strait Islander colleagues that have joined us online this evening. I would like to introduce you to our presenters for this evening. Dr. Shaw is a general surgeon with the Fellowship of the Royal Australasian College of Surgeons, awarded in 2017. His subspecialties interests include thyroid and parathyroid disease, salivary gland pathology, soft tissue tumors, melanoma, and advanced head and neck skin cancer surgery. Dr. Shaw completed clinical fellowship in surgical oncology at the Prince of Wales Hospital and head and neck surgery at the Chris O'Brien Lifehouse. He also holds a Master of Surgery at the University of Sydney. Professor Prida is the head of endocrinology department of Macquarie House University and enjoys managing all aspects of endocrinology. Professor Prida completed a fellowship at the Oxford, UK, where she worked clinically and in laboratory on neuroendocrine disease pathway. She undertook advanced endocrinology training at RMSH. She also has Master of Public Health and in her endocrine work, clinically and research-wise, works on projects to improve endocrine health in society. Dr. Andrumanamani is a full-time clinician over a decade. She enjoys evidence-based chronic disease management and preventative healthcare in high-risk population. As the RCGP supervisor, she imparts a systematic approach to multi-morbidity to her registrars. She champions general practice to medical students from the University of Sydney. Her passion is to encourage chronic disease management as center to women's health. Welcome to all presenters. I will now pass it on to Vani, who will go over through the learning objectives.
Thank you, Serena. So today we are here to assess and investigate thyroid nodules and navigate current treatment pathways and empower patients through shared decision-making with personalized patient care. We are here to interpret investigations for hyperparathyroidism and distinguish between its various causes. And finally, determine when to opt for medical management and when to opt for surgery. And I'll now hand it over to our first speaker.
Okay, so thank you for the kind introduction, and thank you for introducing our team from Macquarie University Health. Let me move to the first slide as we walk through this evening. One of the most common presentations in general practice. We know that functionally thyroid function screening occurs in general practice as routine health, and patients with a strong family history of thyroid disease often warrant screening in addition, above and beyond the standard of care that most people get a thyroid function test at least once a year. But the diagnosis of changes in the gland or nodular change requires clinical examination of the neck and the draining lymph nodes. So the important thing is to work out whether there is a nodule present or not, and is it functional or not. So if we're going to think about it in that framework, we need to understand that thyroid nodules are highly prevalent in the general population, 50% of patients over the age of 50, and granted, many are small and impalpable, but they come up incidentally when patients are screened either by deranged TFTs or in the context of other imaging for other reasons. They're more common in females, and thyroid cancer specifically is also more common and found in females more commonly of middle age. And they're more common in iodine deficient populations and populations who've had previously irradiated head and neck therapy. The flags that one needs to be aware of are when patients tell you about vocal cord change, when there's derangements in the thyroid function tests, and when these signs pop up at an early age. So it's important that you take a clinical exam in your patients, particularly when you notice a change in thyroid function tests as well. And that includes how rapid was the growth of the nodule? Is it tender? Has there been a cough or cold? Has there been a fever? And is there any suspicious or red flags that make us worried that there's invasion into the surrounding structures? And my colleague, Dr. Shaw, will talk about this in the context of the relevance for surgery, where it becomes important as we move through tonight's presentation. So this was not anything new, and it's in the up-to-date guidelines and in the differentiated thyroid cancer guidelines that are evolving. And as you'll see this evening, some of these guidelines are getting updated as we notice that there's a steep rise in differentiated thyroid cancer and what to treat and what is too early to biopsy and what is relevant to biopsy. So let's move to the next slide. So thyroid nodules come in different types, and they are non-neoplastic, broadly speaking, or neoplastic. We're going to move through that this evening and specifically focus on the most common type of neoplasia and how the treatment guidelines have evolved. But we're also going to talk about how we can individualize patient therapy. And we need to think about, in this context, specifically tonight, in the non-neoplastic group, when do we treat if they're hyperfunctioning? And in the neoplastic group, for the common types such as papillary thyroid cancer, how can we individualize therapy as it evolves in our recognition that thyroid cancer generally has a very good outcome. The risks of surgery, albeit low in high volume centres with good surgeons, but there's dynamic risk assessments which we can individualise to the patient's clinical response. And we'll work through that with you tonight. Less than 15% of thyroid cancer is follicular thyroid cancer, and they can exhibit distant spread, and we're not going to go into the aggressive types of anaplastic tonight. Suffice to say that the anaplastics, the medullary thyroid cancers, and the other more unusual tumours do have specific mutations associated with them, and we can treat those in different ways. But we're going to focus on what's common tonight. Next slide. So as we move through solitary functional nodules, we need to think about what's in front of us. And often patients have presented with their thyroid function tests to you as the GPs, and we've found the thyroid function tests to be suppressed. So somewhere in the vicinity, either frank suppression with an overt T4, T3 that's increased, or a T4, T3 that's still in the normal range, but the TSH is somewhere between 0.1 and 0.4, and we'll work through that in the coming slides, or more frankly suppressed. And we need to think about the patient's risk factors, and we need to work out whether that's because there's a dominant nodule within the thyroid gland, and that can be confirmed with the nuclear medicine study and on ultrasound with specific features. And we need to think about what's best treatment in the particular patient in front of us. And that may depend on age, on comorbidities, and patient preference for therapy. We also need to think about whether it's relevant to perform fine needle aspirate biopsy for any evidence of malignancy. Generally speaking, dominant nodules, meaning an overfunctioning nodule, which is solitary in nature, are low risk for cancer, but that doesn't mean that there cannot be cancer. There can be. So we will risk stratify patients and work out whether they need to go on to have an FNA. Next slide. So in treating what's called subclinical hyperthyroidism, which is always tricky because some patients may feel anxious, some patients may have comorbid conditions such as atrial fibrillation that may be exacerbated by this condition. It sometimes may be a little bit more clinical than we think it is. But classically, a subclinical picture is one where the T4 and T3 are compensated, and then the question becomes, do we treat them? Well, what's the evidence base? The evidence base really is that for patients who have comorbid conditions of atrial fibrillation, cardiac failure, and other adverse cardiovascular risks, as well as a history of osteoporosis / frank fractures, we should be considering treating, okay? And particularly in patients who are over the age of 65. And for many of us, as our aging population comes to us as patients, and there's more of a burden of people over the age of 65 years of age moving to the norm of being highly functioning, we need to think, if they're going to be living into their 90s, what is the good quality evidence that we're basing this on to treat them? And there is to date that in this cohort, we should take the sum of age more than 65, a history of bone loss, be that either on bone mineral density or minimal trauma fracture, plus or minus atrial fibrillation, with the consideration to treat, particularly when they're sitting in that TSH realm of around 0.1 or frankly suppressed. The evidence in large-scale trials is still limited, but we do still quote guidelines that you're well aware of from both the Australian Journal of General Practice in 2021 and the American Family Physicians. That hasn't specifically changed recently. Next slide. So to sum up, consider your TSH of if it's frankly suppressed and the patient has comorbidities, then it's worthwhile treating. Negotiate with your patients and track your patients in working out whether they would be patients who do need treatment or over time careful monitoring and then moving to treatment if they become more suppressive. If they're younger than 65 and asymptomatic, well, we may move to observation. Next slide. So if we just one slide back, if we just go back to what we're going to walk through, I think you've skipped one. So just the next slide is differentiated thyroid cancer and the traditional nodule scoring. So next. For what we're focusing on this evening of differentiated thyroid cancer, for the next functional nodule assessment of, we've moved from TSH levels to there is a nodule that we want to consider in the neck. There's an evolving space here where over time we have become less aggressive in treatment. So we're going to walk through the Bethesda categories tonight of what the biopsies mean once you see a patient with a nodule and you return a fine needle aspirate biopsy report. And my colleague, Dr. Shaw, is going to walk you through some of the surgical management of these as well. But frankly, when you get a report of a Bethesda 1, it's inadequate. Bethesda 2 may need some monitoring depending on size, and Bethesda 3 to 6 is atypical, ranging out to frankly malignant, and it will depend on the size and the patient preference as to what to do. Next slide. So the traditional movement through the cancer staging that you're familiar with in other cancers, where we have suspicious nodule, diagnosis on FNA, and then TMN staging at a single point in time where we didn't change over time, didn't really predict tumor recurrence, we have moved on from. And you're going to see that in the coming published American Thyroid Association guidelines that have been approved this year, that regularly get updated with the categories of risk divided in low, intermediate, and high, as well as having now genetic profiling and risk categorization that we can now predict recurrence or not. And we've actually really moved to understanding that thyroid cancer generally has a pretty good prognosis in most cases. Next slide. So you'll get confronted with lots of reports that the sonographic patterns of risk and malignancy come up, and you might wonder what they mean. The suspicion can really be categorized into high, intermediate, low, or very low. And that will then drive whether we move to an FNA and whether an FNA needs to be followed or repeated at different times. Suffice it to say that the guidelines base it around the standards that the American Radiology Association, the ACR, reporting data system uses, and it's based really on the ultrasound sonography of a score assigned to each of the following categories. The composition of the nodule, whether it's cystic, spongiform, so benign versus more solid. The echo, so what it looks like, whether it's anechoic versus very hypoechoic, which is where it gets a higher score. And then the shape, whether it's wider than tall versus taller than wide, which is more suspicious. And the margin, which is either smooth or extrathyroidal extension, is the most suspicious. And all those findings form a category that then gives a final score. And that's how the radiologists report it to us in the TIRAD scoring, which mimics what you're familiar with in the BRAD scoring for breast malignancy. And that's the nomenclature that gets used to then drive us to a score that then makes us read the reports and look at the ultrasound with our colleagues in MDTs together to decide whether something should go to FNA, also in conjunction with the rate of change, how many nodules, and the size of nodules. So generally speaking, the recommendations have been to date, and this is moving sometimes with some more leniency, that TIRAD's 3 nodules, 1.5 centimetres, need follow-up, and if it's more than 2.5 centimetres in FNA, follow-up generally you'll see in reports 1, 3 and 5 years. TIRAD's 4, more than 1 centimetre follow-up and more than 1.5 FNA and follow-up sequentially over time. And TIRAD's 5, even 0.5 millimetre nodule, 0.5 centimetre, beg your pardon, lesions require follow-up and more than 1 centimetre in FNA and annual follow-up for 5 years. But you've got to temper that with your patient, because your patients can also read their reports now. They read it with you, and there can be a lot of anxiety. Next slide. So this is really to help you frame what those radiological scoring categories mean in terms of risks of malignancy. And you can see it's only really out to the TIRAD's 5 ones that get more than 7 points that there's a 35% risk of malignancy, 10% TIRAD's 4. So if we move to the next slide, I want you to think about how we generally approach malignancy in other tumours. We think about the T&M staging, and this is certainly what we've thought about over the last decades in thyroid cancer, but we're moving away from some of this as we move through understanding that papillary thyroid cancer, which is up on the top right here, is really generally much less aggressive in behaviour compared to other malignancies. And that's what we're focusing here tonight. And the new ATA guidelines that will be published later this year will move in line with this, that will decrease our anxiety about the risk of thyroid cancer recurrence per se and what to do about it in terms of radical surgery and what other options we can do in terms of partial thyroid sparing surgery or hemithyroidectomies and downgrading the burden on patients. Next slide. So in terms of the cytological categories then, we need to think about radiology, then moving to fine needle aspirate biopsy, and the suggested approach that we move to in terms of surgery that Dr. Shaw will talk to you about shortly. So in general, as we begin to understand that we don't necessarily need to do a one-stop shop of nodule, malignant, total thyroidectomy, lymph node clearance, radioactive iodine, as they used to do 20 years ago, we can now individualize therapy, and it's evolved in the last 10, 15, 25 years, and each ATA guideline successively is getting more refined to negotiate it to an individualized patient score. And we've really moved down to hemithyroidectomies rather than totals all the time, and Dr. Shaw will talk to you about that shortly. In addition, we have to understand the role that if we've got a nodule that's suspicious looking, we also have the ability to now perform molecular testing that's sensitive and pretty specific to distinguish between neoplastic entities. And we'll talk about that with the role of molecular markers to avoid unnecessary surgery shortly with Dr. Shaw. Suffice to say that will also be integrated into the ATA guidelines. Next slide. So our current framework that we work with commonly in guiding our patients and my colleagues in general practice, we've got to think about where this is headed, and there will be updates in this space. This is what we're used to, and more will be coming later this year. Next slide. So the dynamic thyroid nodule differentiated PTC stratification needs to think about a suspicious nodule, the diagnosis on FNA based on the sampling that's been done, and then the initial risk stratification adapted to the patient's choice and ongoing evaluation in the right patient at the right time and with the right follow-up that we've talked about. Next slide. So if we consider what would have happened in 2020 and 2005 versus 2015 and now 2025, you would have found a patient with a neck mass, palpated it, they would have gone for total thyroidectomy, they would have had radioactive iodine, they would have been kept suppressed for years on end, and they would have been consented, and that was that, and that was the end of the conversation, and they'd be followed up indefinitely, and that would be their story. In 2015, it was probably an incidental finding on some other imaging that they had. They would have been consented for a lobectomy or a total thyroidectomy, and we probably would have kept their TSH around 0.1 to 0.5. We possibly would have gotten them to be part of this, to share decision-making process, but we probably would have just told them that's what we do. Now in 2025, moving forwards, it's very common to have incidental findings come to us as findings on ultrasound, or because there were other reasons to do imaging. You know, the cases of patients who've had CTs of their neck, chest, abdomen, or other PET scans for other reasons, and it's been found for other causes. They've been considered for options of surgery or for possible observation in conjunction with the endocrinologist or surgeon. Radioactive iodine in this context of a 1.3 intrathyroidal PTC was not given, and our TSH goal has actually moved to more of a low to mid-range normal rather than suppressive, and we've guided the patient and allowed them to have follow-up. But we've got to have the caveats that these are patients who are followed up and engaged in the process. So we've moved really away from a one-stop shop to a less burdensome surgery, a less burdensome amount of thyroxine therapy that they require, and over time, less risks in a 27-year-old female of having long-term bone suppression and early bone loss, atrial fibrillation, and it's a guided decision-making process that allows for follow-up. Next slide. But you've also got to consider that just because nodules are small, less than 1.5 centimeters, doesn't mean by location they're not potentially very mischievous and difficult. This was a 33-year-old singer that I shared with another endocrine surgeon, and she came to us with a suppressed TSH, and she was found very much on clinical palpation that she had a small lump in her neck, and she was an opera singer. And when that was further clarified on ultrasound, it was found to be situated posteromedially just right near the recurrent laryngeal nerve, which Dr. Shaw will walk you through soon to let you know that is a very, very difficult spot to operate on. And when that grows bigger, which it eventually will, it can potentially cause major problems with good outcomes in surgery. So this lady had a TIRADS 5 9mm nodule that was PTC proven on biopsy as Bethesda 6, and she did indeed go on to surgery. So it also depends on location. Next slide. And with her surgical location, it was posteromedially in the left mid-pole near the recurrent laryngeal nerve in the tracheoesophageal groove with a very difficult plane to dissect. And potentially, if we'd let it go for a bit longer, it would have eroded into the trachea and the recurrent laryngeal nerve, which would not have been good for her singing career, which suffice to say, she is doing very well. So it does depend on location. She's gone on to do well, and she has had a total thyroidectomy, and we can monitor for recurrence in her with thyroglobulin levels, and to a TSH suppression, we're sitting around the 0.1 to 0.3 at present, but we probably can relax that now a few years on. And we do need to be careful of a case-to-case basis for all our patients and how we monitor them. And how we monitor thyroid malignancy is much the same as in other malignancies. We have the ability to use tumor markers. In a totally thyroidectomized patient, we have the ability to use long-term thyroglobulin levels as our follow-up. And that's important for your management with patients in order to understand that there's no role for thyroglobulin assays before total thyroidectomy. It's after total thyroidectomy that a change in doubling time and rise in thyroglobulin is important. And it's important to have valid platforms, particularly in the context of patients who have anti-thyroglobulin antibodies that can interfere with the assays and make it difficult to interpret. And that was some of the work that we've performed in Australia over the years to validate our assays and the platforms and interference. Next slide. So to consider the next patient, I'm going to leave this in Dr. Shaw's domain shortly, but we're going to take this through in his presentation shortly. And you can just have a little think about how we can personalize biopsies in multinodular thyroids. And I'll leave that with you and we'll come back to it in the interest of time. Next slide. So the learning points are the incidence of DTC is on the rise, and serial evaluation and dynamic risk stratification is important. Patient preference and care goals are essential. Next slide. Primary hyperparathyroidism, I'm going to skip through to suffice to say that Dr. Shaw is going to talk to you about it, but most of the time it's single adenomas. Next slide. Secondary hyperparathyroidism is usually seen in association with kidney disease, and tertiary is in transplant patients with chronic renal failure with autonomous production. Next slide. So in primary hyperparathyroidism, it's usually an incidental finding. It's more common in women than men. Rarely does it cause a hypercalcemic crisis, but you've got to be aware of the neurocognitive deficits. It's an elevated serum calcium and an inappropriately elevated PTH. Next slide. The investigations are essential and we need to exclude differentials. It is essential that we rule out patients who have got familial conditions, and it's essential that we actually only triage patients who need treatment, who've got osteoporosis and evidence of calcium disorders chronically with nephrocalcinosis. Next slide. So the indications for surgery are long-standing. They've not changed. In 2014, the NIH guidelines are absolute indications of a corrected calcium above 2.85, osteoporosis, and a 24-hour urinary calcium excretion that is elevated with biochemical analysis. Renal calculi and ultrasound also very helpful to be seen. Those fit for surgery, and Dr. Shaw is going to talk to you about that. And we need to be aware that we can also have indications for surgery where hypercalcemic crises and medical therapy has failed. Then we need to consider surgery as well. Next slide. Localizing studies are essential, and it needs to have dual concordant imaging, and that involves ultrasound, next slide, and also sestamibi scans. And it's essential to get accurate dual concordant scans. Next slide. 4D CT is not new. It's been around for quite some time, but it's essential to understand that it gives additional sensitivity if we haven't localized on ultrasound and sestamibi or where the results are discordant. It does have a significant radiation dose. Next slide. And therapy involves, first line for primary hyperparathyroidism, surgery. We can use calcimimetics or bone resorptive medications, but these are usually short-lived. And the minimally invasive surgery in the right hands can be very successful and give patients a lot of benefit. And I'm going to hand over to Dr. Shaw, leaving you with some images of one of the chapters from an Australian textbook.
Thanks, Veronica, for that, Dr. Prita, for that very comprehensive and succinct summary of thyroid nodules and the new algorithms of management. I'm just going to share my screen. And there is a fair bit of overlap in terms of the information. So, and Veronica's, Dr. Prita's summarized it very well and in a systematic fashion. So I'll probably brush through a few of the slides in the interest of time. And then to reinforce some of the concepts on newer algorithms of care, I've got a couple cases we'll go through. So just as what I want to sort of cover in this session, and I'm not going to go through extensive details on surgery or anything because that's probably unnecessary. Is that, as Dr. Prita mentioned, the previous one size fits all management approach of a total thyroidectomy and plus or minus radioactive iodine and TH suppression is no longer the case. And she gave a very nice slide demonstrating at 10-year intervals of how things have evolved in that. So that there is definitely a trend towards de-escalation of surgery from a surgical perspective. And we're now trying to incorporate newer evidence and molecular knowledge into those treatment algorithms. And I'll also talk about the concept of active surveillance. So we've gone through this already, but I guess when you're framing your approach and looking at the flow diagrams of how management algorithms, you need to consider the patient as well. And Dr. Prita already mentioned this, but we look at any history of childhood head and neck irradiation, whether they grew up near Chernobyl or accidents and overseas where they get a lot of head and neck radiation as a child, family histories of thyroid cancer syndromes, and looking at other symptoms which can be a sign of a rapidly progressive or aggressive malignancy, such as rapid growth of a neck mass, lateral lymph nodes. They're all taken into account. As we mentioned, there's thyroid nodules are very common. This is just another slide to show you that the vast majority, as we know, are benign, and the different pathologies which are common in both benign and the malignant types of thyroid cancers. I will cover a little bit more pathology briefly, just to discuss some of the newer concepts of pathological nomenclature and how that influences how we manage things and our concepts. I find this quite a good slide. This is a slide showing the recent, well, since the 80s, I guess, the increasing incidence of thyroid cancer diagnoses. And as we discussed earlier, there's a 3-to-1 propensity or difference from females to males. But despite this, I'm just going to try and get rid of the, oops. Despite the, I was just trying to get rid of the sidebar. I don't know if you can see on my screen other people involved in the chat, but it's a little bit distracting. I'm sorry if that is the case. So despite the increasing incidence, there's a flatline mortality, and we know that differentiated thyroid cancers do really well. There's upwards of a 97% 10-year survival across all differentiated thyroid cancers. So the question was asked quite a while ago, is that a true increasing trend, or are we diagnosing more with incidental findings on other imaging and stuff? And we'll come back to that in a minute. We've also already gone through this algorithm. I think this is just another nice summary of this one's from UpToDate, and we've already discussed it. But as just to reinforce, because there were a couple of questions in the chat, I guess when the TSH is subnormal, then you want to look at the T3 and T4 to see if that is within normal limits, or if it's if they have any features of hyperthyroidism. And the next stage of investigation is getting that thyroid scan to find out if it's a specific toxic nodule. But in general, when you're heading down this pathway, I think the more appropriate line of referral is to an endocrinologist for complete, rather than a surgeon, for a complete evaluation and discussion of different treatment options if they do have subclinical hyperthyroidism. And Dr. Preet has given a very nice summary of the newer guidelines and approaches to that. I think when they start to demonstrate a more of a structural abnormality, then they need comprehensive workup as the other pathway describes. So we've already gone through the TIRADS, and this was updated in 2017. And I guess just to reinforce again, if someone has a solid hypoechoic nodule, which we see quite commonly, that automatically puts them into a TIRADS 4 category with on the data 9% risk of malignancy. And often patients, as everyone will see in reports, they have multiple nodules of different categories. And in general, the approach, we can't biopsy all those nodules. And in general, the radiologists are pretty good at providing recommendations now on their ultrasound reports, but we biopsy the highest category nodule, and the largest, the most suspicious. I find it quite useful having ultrasound in rooms and able to sort of look at things myself and be able to work out which ones look the most suspicious to me, because sometimes it's difficult to interpret it all from the reports. But it is very good to have the systematic approach to reporting thyroid nodules. Obviously, we discussed then once you've got the ultrasound report and it gives a indication for biopsy, then we get now a systematic report on thyroid cytology. And this was actually updated in 2023. And some of the nomenclature has changed, and also they've revised the reports now that they need to give the numerical number, so Bethesda 4, but also give a diagnostic category to avoid uncertainty and misinterpretation, and also allows better data collection. But if you this table is a little bit busy, but it does, and it probably overestimates the risk of malignancy across the board, because this data set is based on things that evolved since the previous iteration of the Bethesda classification system in 2017, and most benign and some Bethesda 3 nodules won't go on to have surgery, so we don't know the true rates of malignancy there. The other thing to point out, and I'll go into this in a minute, is that if you take away a newer pathological classification called NIFT-P, then the rates of malignancy are a little bit lower. The other thing to point out when I'm interpreting Bethesda reports is that if I see the words of predominant infiltrates of oncocytic cells, to me that carries a slightly higher risk, and I'm more likely to recommend a diagnostic surgical approach if that is the case, because they do portend slightly more aggressive tumors, and often we need the full architecture from surgery to get a true answer. Obviously, as we go into category 6, we're talking about definite malignancies, whether it's PTCs or more aggressive neoplasms, and those are the ones that are heading towards surgery. This slide just demonstrates some of the newer algorithms that Dr. Prieto was mentioning. And this comes from the Bethesda, updated Bethesda classification. And it incorporates concepts that are still evolving and definitely still evolving in Australia, where we look at the Bethesda result, and there is different treatment algorithms that are evolving, including molecular testing versus proceeding just to a diagnostic lobectomy for those ones where we've got persistent atypia of unknown significance. I'm going to keep going through. So this is the updated nomenclature for follicular lesions was updated in the 2022 WHO classification for thyroid neoplasms. And I'm not going to go into it in depth because I don't want to bore everyone to sleep. Although I find it interesting. But essentially they've revised it to because we're getting more and more information and data about and how a lot of these neoplasms behave, both based on the molecular information we're getting from genetics, and also more thorough studies. So we're now getting better information about the molecular patterns of certain pathologies and also their long-term biologic behavior. And hopefully we can use this information to stratify how to treat and individualize our treatments for those particular patients with those neoplasms. So a couple concepts I just want to cover, because you might notice it on some of the reports and stuff, is that the WHO new guidelines recommend going away from using the term multinodular goiter. So you might see on pathology reports that now they're referring a lot of it to thyroid follicular nodular disease. It's the same pathology, but just a newer nomenclature for it. And you can see in this slides, you see the multiple nodules throughout the gland, cystic spaces, and colloid formation. There's also multiple benign variations on this concept. So there's we talk about follicular thyroid adenomas, and then follicular thyroid adenomas with papillary architecture. And a lot of these are actually clonal. So that's sort of an important concept, because when they're clonal, they can have a potential for transformation to malignancy, although very minute. The other one where the nomenclature was changed is we used to talk about Hürtel cell adenomas. But Hürtel cell was actually a bit of a misnomer, and he used the term to coin parafollicular C cells. So the new wording is oncocytic adenoma rather than Hürtel cell adenoma, and you might see that on the pathology reports. Probably one of the last concepts I want to talk about in terms of pathology is non-invasive follicular thyroid neoplasms with papillary-like features, NIFT-P. So that's a definite mouthful. But it used to be termed follicular neoplasms with the wording of papillary carcinoma in it. And that provided a lot of oncologic anxiety for patients, because we know that they behave very well, and there's basically no risk of metastases or progression from them. So when the pathologists look at giving this report, there's very stringent criteria, which I couldn't regurgitate at the moment. But it's very clear diagnostic features. Unfortunately, it's very difficult to diagnose that on molecular testing or on an FNA. And that's why when we looked at the newer Bethesda things, when we take away, when we get the full pathology, then we have a second category for NIFT-P. The bottom two areas were sort of extrapolated from another presentation, more heavy on the pathology, but you can see that just in terms of a lot of the other pathologies, we're getting a lot more molecular information, and this helps guide us in terms of whether it's gene rearrangements or specific mutations on how these particular things behave and how we need to treat them. So I think that one more slide on pathology is obviously we've talked about the increasing rates of papillary thyroid carcinoma. And the only new trend in nomenclature there is they've taken the term microcarcinoma away from tumors that had less than 10 millimeters in size as a separate subtype. So they're all just called papillary thyroid carcinomas. We do subcategorize them into classic type or subtype because most of the subtypes have a more aggressive phenotype and behavior. So we want that information, particularly on our synoptic reports. And we talked about the mutations there. So I just want to go into a few cases to hopefully illustrate some of these concepts, and hopefully I don't run out of time too quickly. So these are just a couple of patients I've had in the somewhat recent past. So the first one is a 72-year-old who had an incidental finding of thyroid nodules. He's had a significant history and recent ill health where he had full chemoradiotherapy and radiotherapy to the neck for Hodgkin's lymphoma, was diagnosed in 1978. So that portends increased risk of thyroid cancer. He also had a mitral valve replacement and some other significant more recent procedures, and was currently therapeutically anticoagulated. He was pretty well and high functioning, had a good history of exercise, and he was very adverse to the potential of surgery. Now, he had gone down the treatment pathway we talked about before, where he had a had a solid isoechoic nodule, which was 22 millimeters in maximum dimension, TIRADS 3, but no cervical lymphadenopathy. Appropriately, had a biopsy. Unfortunately, the first biopsy came back indeterminate, and the second biopsy again came back indeterminate on repeat. There was no evidence of thyroid antibodies to suggest thyroiditis, and his TSH was normal. So I guess this is just Serena, if you don't mind putting that survey up. What do you think he should have done? Do you think he should have a total thyroidectomy, a diagnostic hemithyroidectomy, just observation, or what other options are available? So I just thought I'd put a poll up and see if we can get a quick summary, and we'll just leave it up for about 30 seconds. And I think, as Dr. Prida was mentioning, I think now we've gone away from the paternalistic and didactic approach of doctors telling patients what we can do and we should do, and trying to really give them informed decision making and shared decision making. And he was pretty firm in that he was reluctant to have surgery. Serena, do you want to summarize and see what we got so far? So we got, yeah, surprisingly, as a big vote for observation or a diagnostic hemithyroidectomy. And we can maybe try and tease out what the other options are in a bit. I think you can close that. I'll just go to the next slide. So again, just reviewing. So he was Bethesda 3. His risk of being malignant based on that is about 22%. This slide is actually based on the previous Bethesda data. But I've highlighted the categories of 3, 4, and 5 because there is still a little bit of uncertainty of what should be done for them and what the options are. So we were talking about molecular screening. And this is based on the better understanding we have of the biology of thyroid cancer. One of the tests that's available overseas is the ThyroSeq, and it's version 3 now. And it runs DNA and RNA sequencing, looking for the 4 kind of main classes of molecular alterations, copy number, point mutations, and other variations. Unfortunately, currently still in Australia, this is not Medicare rebatable. Its cost is significant. It's $2,100 and is is sent through Douglas Hanley Moyer to Pittsburgh, and the turnaround time is 6 weeks. But if you compare it to the pathways overseas, currently 70% of patients with a Bethesda 3 in the US and Canada will get molecular testing. So I expect in a few years' time this will be more of a standardized approach, an option in Australia, but currently it's quite limited. It's very costly, but it is an option to discuss with patients. It is very useful for downstaging or providing additional risk stratification to potentially personalize their surgical plan. But essentially, it's very good for downstaging disease. This is one of the outputs you get when you get your results back from them. And they give you a very nice colorful flow chart, which says that there's been no alterations. And then the risk of cancer or that concept of NIFT-P is 3 to 4%. So if you get that, then you can safely say, oh, look, I think you're very low risk. We can observe things as a lot of people rightly pointed out in the discussion group. It does look at a variety of other mutations, and sometimes it can actually upscale your non-diagnostic biopsy or indeterminate to one that shows it's got BRAF-like mutations, and you have a more appropriate surgical plan that could even be heading towards total thyroidectomy rather than a diagnostic hemithyroidectomy at first. So it's very useful at risk stratification and personalizing it. So this is that chap's result, and this is the result you get back for them. And so for him, it came back as there was no mutations identified, and his probability of having cancer in NIFT-P was 3%. So he was lucky in that he was able to avoid surgery, and that was his wish. And he's just under an observation pattern. I think this slide will probably just brush through. It's a bit busy, but it's incorporating demonstrating how they're incorporating molecular testing and routine treatment algorithms for atypical and indeterminate nodules in the US system. And move on. So I'm going to move on to another case. This one was a 77-year-old lady presenting with another incidentally identified thyroid nodule on PET screening follow-up for breast cancer surveillance. So she was a very lovely little short lady with a very short neck, not an ideal body habitus for surgery. And unfortunately had recurrent oligometastatic breast cancer and was under treatment for that. She had a few other comorbidities. And so this is one of the tricky things when we start, and Dr. Prita and I would be seeing some of these patients fairly regularly where they get incidental diagnoses. So she had a thyroid ultrasound to work up that PET avid lesion in the thyroid. It showed a bit of a mixture of multinodular goiter, still some of the old nomenclature. But they perceived that the PET avid location was correlated to a 7 mm calcified nodule at the junction of the isthmus and the left thyroid. Now, if normally we wouldn't probably biopsy that. We've just had a thyroid ultrasound, we had that 7 mm nodule. I don't think any of us would really rush to be biopsying that. But it was PET avid, and that sometimes portends a bit more aggressive behavior, and potentially associated with a BRAF mutation. And the oncologist organized for a FNA. So this lady came to me with a tiny microscope, a 5 to 6 mm nodule in the isthmus or left lobe, but had a positive diagnosis for papillary thyroid carcinoma. So again, this is another one where you think, what should she have done? Should she have a hemithyroidectomy? So she's got a confirmed cancer this time. It's no longer indeterminate. A total thyroidectomy or some sort of ablative procedure, which we haven't really gone into. What are the options? And what is her and again, her preference was probably to avoid surgery. So it took a bit to sort of explain the natural history of papillary thyroid carcinoma and give a bit of reassurance. And I do that with all my patients. So for her, I guess, we need to look at the data as well. So, and that's what they started doing, I guess, originally in Japan, when they first noticed those graphs of increasing rates of papillary thyroid carcinoma. I just realized we're running out of time. I'm going to speed through very quickly. So they basically asked the question, do we need to treat all these papillary thyroid carcinomas? And they decided to run some really good systematic trials. And we have quite a bit of data back from this now. And this is called active surveillance for small papillary thyroid carcinomas. And the inclusion criteria evolving, but you can see this is one of the earlier meta-analysis back in 2019 showing there's really good patient numbers from Kuma Hospital in Japan, South Korea, and Memorial Sloan Kettering, where they have really high volume treatment and excellent centers. This is some of the data. So they looked at what the 5-year outcome of all those pooled patients. And active surveillance mean rigorous, 6-monthly ultrasound by the same practice to see if there's any signs of progression. And if there's progression, they consider surgery. So when they looked at the pooled analysis, only 5.3% had any signs of significant progression after 5 years. And I think my slide's slightly limited, but only 1.6% had any evidence of lymph node metastases. So it sounds like a very safe alternative. This is another nice graph graphic to show the natural behavior of these tumors. This is from the Memorial Sloan Kettering group, and they included papillary thyroid carcinomas less than 15 millimeters in size, and it shows some show some early tumor increase in size and will head towards surgery. But at 5 years, 80% had not shown any growth and very stable pattern, again showing it's quite safe. This is the inclusion criteria and how we decide which patients are suitable. And so essentially patients that are suitable are ones with a solitary thyroid cancer. There's evidence that there's good thyroid parenchyma around the area. I'm going to go through some of these slides quickly because we don't have much time. And then there's also, your borderline candidates and inappropriate candidates. And I've had a few very young 20-year-olds with thyroid cancer, and I've given them a lot of reassurance that there's a very treatable condition and, we can monitor things. But I'd be very reticent to offer those. I wouldn't offer those active surveillance because we don't know the 40, 50 years sort of long-term follow-up from this program. This is how we help decide on which patients are suitable. And this is from that Japanese group. You're talking about which position of where the thyroid cancer is. So if you're looking at this graph, on the left, position A is an ideal candidate. If it's a small one, it's within the thyroid, it's not near any critical structures. We also, as Dr. Prita showed that really nice case before, we look at the angle it forms with the trachea. And that's quite takes a lot of expertise in ultrasound to look at the angle of the cancer. But that gives us an idea of what's suitable and what's not, the risk of tracheal invasion or if you're looking posteriorly, invasion of nerve. So we have quite, strict criteria on how we diagnose them. I haven't covered, but in the future we will be talking about, other options for management of thyroid nodules and thyroid cancers, because that is starting to come into play overseas, like ablative procedures. But at the moment in Australia, those approaches are very novel and not sort of widespread. I'm going to quickly zip through a case for primary hyperparathyroidism in a minute. So Dr. Preet has already gone through the indications and how the appropriate workup for patients with hyperparathyroidism to determine which ones are likely to have primary versus other causes of hyperparathyroidism. And I think that's a very important and sometimes difficult approach is to figure out what the cause is. And it's good to have sometimes MDTs, from or clinicians you can speak to for additional advice and sort of in the workup. But basically, which patients should be referred for surgery? So symptomatic patients who are fit for surgery with a life expectancy greater than 10 years are definitely ones that probably suitable. Importantly, one thing I want, and I'm going to go through a lot of this is referencing some new Australian guidelines on the management of primary hyperparathyroidism, and I'll put a little link up to that. It's a very, very good resource that I think it'd be a fairly succinct and question sort of targeted resource that it'd be very useful for practitioners seeing these patients to have a look through. One of the comments to that is the diagnosis of primary hyperparathyroidism is biochemical and not reliant on corroborative imaging. Patients who meet the criteria for surgery should be referred to a specialist surgeon for opinion regardless of imaging results. And I think sometimes we just, I've noticed that people will only refer when they have definitive evidence on imaging of a parathyroid adenoma. And I think that's probably a bit premature. I think it's very important to sort of have a thought about the potential in appropriately selected symptomatic patients with primary hyperparathyroidism, irregardless of the imaging. It only just influences how, as a surgeon, we approach it. If there's no targetable lesion on any of the imaging modalities, then unfortunately they have to have a 4-gland operation, which is slightly bigger, but usually people tolerate quite well with low risk of complications. It is much nicer, and one of the nicest operations you can do is a minimally invasive targeted parathyroidectomy, and sometimes it can be a very quick and beautiful operation, but that's not always the case. So I'd love to see the big parathyroid adenomas that are seen on imaging, but that's not always the case. Just noticed the time, Serena. Sorry for that. I guess these are the guidelines that I think are very useful, and so I think if you get a chance, and maybe there can be a link in the seminars summary just to reference those guidelines, because they're very concise and useful answers to a lot of questions you'd have on managing patients with primary hyperparathyroidism. And there's some good flow diagrams in there too. I think we were running short but maybe if there's any critical questions that we haven't had a chance to answer through the chat that Vanny wants to highlight.
There was just the one on GLP agonists and thyroid cancer.
Yeah, so I think I just quickly wrote a comment there. I couldn't see this specific question, but in terms of the GLP-1 receptor agonists, which we use a great deal of in the weight management space, as many of you are aware, is not borne out in the literature in either the large-scale studies in papillary thyroid cancer. It was in the rodent models, because rodent cells have got calcitonin cells in them. In the rodent models, there was a theoretical risk of medullary thyroid cancer, which is an inherited genetic mutation of the RET proto-oncogene, which is not clinically what we're talking about here tonight, but it certainly hasn't been borne out in the literature. So at the moment, you can reassure your patients that the misinformation on the internet for papillary thyroid cancer and GLP-1s is not borne out by any evidence base in the literature whatsoever.
Excellent. Thank you. Thank you so much to both our presenters today. Back to you, Serena.
Thank you. So I did see someone asking for the slides. We'll be sending out the slides tomorrow, and then the recording will be available next week if you missed anything. On that note, I would just like to extend my thanks to Veronica, Douglas, and Vani for presenting, and everyone who joined us online. We do hope you enjoy the session and you have enjoy the rest of your evening. Thank you and good night, everyone. Bye.
Thank you very much.